Welcome to the deep dive. So you're here because you've got that toxicology exam coming up, right? And that's exactly what we're focusing on today. We've got these PDFs, basically your core materials on tox management.
Exactly.
Our mission, pretty straightforward.
Yeah.
Nail down the fundamental concepts, the absolute must-knows from these docs, so you feel solid for the exam.
Think of it like building your foundation. We're not getting lost in the weeds today, just focusing on those core principles you absolutely need. These documents are that bedrock.
Okay, cool. Let's jump right in with the first one, Toxicology M5T1.pdf. It starts by talking about complementary aspects in management.
Right. It makes the point that, vital support, airway, breathing, circulation, keeping things stable, that's step one.
And specific treatments, too, like antidotes or ways to get the poison out.
Sure, reducing absorption, increasing elimination, all that. But the document says, that's not the whole story. There are these other pieces, these complementary aspects that are just as critical.
Okay, so what are some of these complementary aspects? What's fundamental there?
Well, fundamentally, it pushes for a more holistic view right from the start in the ER. It's not just about fighting the toxin itself.
Right.
You need to understand the why behind the intoxication and anticipate what else might go wrong. These other factors are really integral.
And one of the first things it mentions is the intention. Why did this happen? Apparently, after booze, suicidal intent is the, most common reason for acute non-alcoholic poisoning.
Yeah, it's quite striking. The stats mentioned for Spain in 2017, over 3,600 suicides, double the traffic deaths. It really drives home that this isn't just about accidental stuff.
Wow. So often it's linked to mental health crises.
Precisely. And that puts a fundamental responsibility on emergency docs, doesn't it? You're often the first point of contact.
So you need to recognize the signs, maybe.
Exactly. Recognize those suicide risk indicators, know when to get psychiatry involved. It's a basic skill. The immediate medical issue, the intoxication, comes first, but then it transitions to a psychiatric concern once they're stable.
Makes sense. Then there's the legal side. This document says intoxications are legally non-natural, treated like accidents. But apparently that's not always how it plays out in practice. There's a gap.
Yeah, the document notes that gap. Healthcare professionals don't always apply this understanding consistently.
What do you reckon that is? Just lack of training, or is it more complicated?
I think it's probably a mix. The ER is hectic, right? Clinical priorities are screaming at you.
Sure.
And the legal stuff, the reporting, the classifications, it can be complex and maybe not always emphasized enough in training.
So it needs more focus.
Definitely. Better training, maybe clearer protocols to connect that legal requirement with what actually happens on the floor. It impacts care, potentially legal stuff later too.
Okay. The PDF also brings up EPI, personal protective equipment.
Ah, yes, PPE.
We think infections, usually, but it's just as basic for chemical hazards, things absorbed to the skin.
Totally. Even the patient themselves, if they're covered in, say, pesticides, could be a source of exposure for the staff.
Right, so protecting ourselves is fundamental.
It is. Not just for us, but so we can actually keep providing care, The doc mentions the range from basic gloves right up to those full-on sealed suits. Figure 2 shows basic skin decontamination gear. It's about preventing that secondary hit.
Gotcha. Then it introduces toxicological rhabdomyolysis. Basic concept.
Rhabdo, yeah. Basically, muscle gets damaged, breaks down, and leaks stuff into the blood. Nasty stuff like myoglobin, potassium, CK.
And this happens a lot with poisonings.
It's a common complication, yeah. And knowing how to manage it is absolutely fundamental, mainly to stop the kidneys from failing.
So the key is understanding that damaged muscle leaks bad stuff, and you need to protect the kidneys, often with fluids.
That's the core principle. We'll see later just how many different things can cause it, but recognizing the risk and flooding the patient with fluids early on is key.
Okay, and similar idea, it defines methemoglobinemia.
Another key tox disorder.
Main sign is cyanosis bluish skin that doesn't get better with oxygen.
That's the classic fundamental sign. The blood itself can't carry oxygen properly because the hemoglobin's iron has been changed, oxidized.
From Phe2+ to Phe3+.
Exactly. So giving oxygen doesn't fix the underlying hemoglobin problem. Knowing the basic treatment, mainly methylene blue, is essential.
And this first PDF rounds out by mentioning hypersensitivity reactions and those emergencies tied to psychotropic drugs like NMS and serotonin syndrome.
Yeah, it just briefly introduces them. It's basically setting the stage, reminding you that managing poisoning means looking out for a whole range of potential complications, not just the direct toxic effect.
It's a broad picture.
Absolutely. Rhabdo, methemoglobinemia, immune reactions, specific drug syndromes, all fundamental things to keep on your radar.
All right, let's switch gears to toxicologia, M5T3.pdf, digging deeper into the medico-legal basics. It hammers home that legal point again. Intoxications are non-natural, like accidents.
And that gap in practice persists.
So even if doctors don't often get sued for honest mistakes in treatment, their notes and actions are super important legally.
Fundamentally important, yeah. What you write down, what you do, that becomes part of the legal record. Critical in court, especially if it involves, say, a car crash or potential crime.
And a core concept here is the injury report, the parte de lesión.
Right. That's a basic legal requirement. Because in legal medicine terms, any poisoning causes a lesion, an alteration from some agent.
So for the exam, what's the absolute must-know about this parte de lesión?
The legal obligation. Article 262 of the Criminal Procedure Law says you have to report public offenses, which includes intoxications. Not doing it is punishable. That's fundamental.
Okay, don't forget to file the report. What needs to go in it?
The basics. Your ID, patient's ID, description of the intoxication, how they say it happened crucially, their story, not your judgment.
Right, stick to the facts as reported.
Exactly. Then the prognosis, using those legal timeframes, minor, 15 days. Less serious, 15-30, serious 30. Avoid saying reserved prognosis. It has no legal meaning.
Good tip. And patient destination, time, date, your signature.
The standard stuff, yeah. Get those basics right.
And there's also a judicial report, the parte judicial.
Yes, another basic legal communication tool. Sometimes used if you suspect a crime, but there's no obvious physical injury. And it mentions specific, more detailed forms for things like gender violence cases.
Okay. What about if the patient dies from the poisoning?
That's automatically a non-natural death, legally. Triggers specific procedures.
Meaning?
Meaning you must notify the judge and forensic doctor. A judicial autopsy is required, not a clinical one. You don't fill out the usual death certificate.
Instead, you file an injury report stating the death.
Correct. That's the fundamental legal process based on the criminal procedure law. Remember that for the exam, non-natural death equals judicial autopsy.
Got it. Now, discharging the patient, especially if they had suicidal intent.
Specific legal rules apply based on patient autonomy laws. Your discharge note needs the destination. Often includes psychiatric follow-up if it was self-harm. Remember, the acute tox is medical first.
And if they want to leave against advice?
That's where Law 41-2002 comes in. You can only let them go if they truly understand the risks, aren't a danger to themselves, and aren't a public health risk. Those are the fundamental criteria.
And if they don't meet those criteria and refuse treatment?
Then you might need to consider involuntary admission after notifying the court, maybe even restraint if necessary. If they just leave, you notify authorities.
Okay. And minors? Different rules for consent?
Yeah, tied to the Constitution and patient autonomy law. Basically, 18 is adulthood. But those 16 or 17, if not emancipated, can generally consent to routine care.
Like exceptions.
Clinical trials, artificial insemination, basic exceptions. Under 16, their opinion matters depending on maturity, but parental consent is needed for serious risks. The Medical Code of Ethics gives more practical guidance.
Right. Last point from this PDF. Getting and handling samples for legal tests.
Crucial area. The basic principle. No judicial order, no clear medical need. The patient can refuse toxicological sampling.
You can't just force it.
No, that could be punishable. But you still have that duty to report suspected crimes like impaired driving.
So how do you handle that?
You can file a judicial report or just document the clinical signs of intoxication very clearly in the medical record. That documentation itself is evidence.
Okay. And if you do get samples legally, what makes them valid in court?
Needs to be done right. Basic requirements. Non-alcoholic skin disinfectant, specific sealed tubes check local protocol, and a demonstrable chain of custody.
Chain of custody.
Yeah, a documented trail showing who had the sample when, from collection right through to analysis. You need basic records of all those times. Fundamental for legal validity.
Makes sense. Let's shift to toxicology M5T4.pdf, protecting healthcare staff.
Right. Back to PPE and safety.
It says major chemical contamination in the hospital is rare, beyond standard precautions. But emergency docs need to know about major chemical accidents.
Yeah, think big scale, like mass casualty incidents, but with the added complexity of decontamination and preventing the hospital itself from getting contaminated. Staff protection is paramount there.
And it mentions historical examples.
Bhopal, the Tokyo subway attack, really highlights the potential scale and the need for specialized teams like the NBQ units. They handle these major events and train civilian responders.
But more commonly, ERs see minor chemical accidents,
Yeah.
like industrial or farm exposure.
Exactly. Someone gets a significant skin exposure. That's where staff precautions using the right EPI become really critical to avoid self-contamination.
So EPI again. Remind us of the basic definition.
Anything worn or held by a worker to protect against health or safety risks, subject to basic EU standards CE mark, EN standards, and categorized into levels.
Levels A, B, C, D, or I, 2, 3.
Both classifications are used, NFPA AD and European 3. Fundamentally, they describe the degree of isolation and protection. You need to know the basics of what each level entails for the exam.
So level A or 3 is max protection, like for firefighters in the hot zone.
Exactly. Fully sealed suit, self-contained breathing apparatus, SCBA, heavy-duty gloves, boots, total barrier.
Level B or 2 still need breathing protection.
Yeah, still SCBA, but maybe the suit, gloves, boots are a bit less chemically resistant for when the respiratory risk is high but skin risk is lower.
Level C or I, or toxic concentrations.
Right. Less skin risk, usually a full face mask with a filter cartridge, not SCBA. Less protective suit, gloves, shoe covers. Think maybe Ebola response type gear.
And level D is just standard hospital stuff. Gloves, gown, mask.
Pretty much. Basic protection from minimal contamination risk. The figures in the document give good visual cues for these levels.
Okay, so basic preventive measures for staff.
Fundamentally, have protocols everyone knows. Always suspect potential skin absorption with any chemical exposure. Start with the highest reasonable level of EPI.
And decontamination.
Crucial. Do it in a designated, isolated area with a shower or tub. Initial responders need gloves, mask, gown, eye protection, maybe level C, depending on the substance.
What about the patient's clothes?
Remove them carefully. Bag them as toxic waste. Group 4B hazardous waste. Follow hospital rules. Remove metal objects, too.
Decontaminate first, then assess.
Ideally, yes. Unless they're critically unstable, then stabilize first. But everyone involved needs appropriate EPI during stabilization. Keep using gloves even during assessment until they're clear.
And Table 1 lists substances with skin toxicity potential.
Yeah, it's a helpful basic list. Categorizes them. Some only penetrate broken skin. Others are dangerous even on intact skin due to high absorption or toxicity. Good to be familiar with examples like hydrofluoric acid, pesticides, nerve agents.
All right. Let's tackle toxicologia M5T6.pdf, toxicological rhabdomyolysis fundamentals. Definition again.
Basic skeletal muscle injury, releasing intracellular contents, myoglobin, CK, potassium into the bloodstream. Figure 1 shows it visually. Normal muscle, then the membrane breaks, stuff leaks out.
And the basic mechanism. How does it happen?
2 main ways. Direct trauma to the muscle membrane, or the muscle cells run out of ATP, their energy source.
Lack of ATP messes things up.
Big time. It disrupts the calcium pumps. Calcium floods the cell uncontrollably, causes sustained contraction, uses up even more energy, activates destructive enzymes. The cell basically falls apart.
And trauma adds ischemia and inflammation on top.
Right. That ATP depletion pathway is key, though. Remember that fundamental link between energy failure and cell breakdown.
Causes are broad, both toxins and other things.
Very broad. Table 1 lists a ton of substances, drugs of abuse like alcohol, heroin, cocaine, medications like statins, neuroleptics, toxins like ethylene glycol, carbon monoxide, even snake venom.
So for the exam, know the range of potential toxic causes.
Exactly. Don't need to memorize every single one, but appreciate how many different types of things can trigger it. And Table 2 lists the non-toxic causes important for differential diagnosis. Things like extreme exertion, seizures, crush injuries, infections.
Clinical signs can be vague, muscle aches, cramps.
Often nonspecific, yeah. That characteristic dark reddish-brown urine from myoglobin is a clearer sign, but not always present.
Lab test.
The key diagnostic marker is a very high creatine kinase, CK, level in the blood. Specifically, the muscle fraction, CKMM.
Not the heart fraction, CKMB.
Right, CKMB might be up a little, but CKMM will be way, way up. Urine dipstick positive for blood can suggest myoglobin, but it's not definitive alone.
Complications are the main worry, especially kidneys.
Acute kidney injury, AKI, is the big one. It's multifactorial: poor blood flow, myoglobin blocking the kidney tubules, iron toxicity. Figure 2 shows how it happens.
The risk isn't directly tied to how high the CK is.
Not always a direct correlation, no. Fluid loss into the damaged muscle makes it worse, too. Early, aggressive 5E fluids are the best prevention. That's fundamental.
Other complications.
Electrolyte problems. High potassium, hyperkalemia, is dangerous for the heart. High phosphate. Low calcium initially, then maybe high later. DIC, that clotting problem, is rare but bad. Compartment syndrome, where swelling cuts off blood flow in a muscle group, needs urgent surgery.
Treatment is mostly about preventing those complications.
Primarily, yes.
Yeah.
Intensive 5E fluids, usually normal saline, start them ASAP. Aim for really good urine output, like 200, 300 milliliters per hour. That's the most effective thing against AKI.
What about diuretics? Bicarb.
Mannitol might be used if fluids alone don't get the urine flowing, assuming the heart's okay. Furosemide is controversial, might acidify urine, worsen myoglobin precipitation. Bicarb, to alkalinize urine, pH 6.5, is sometimes used to prevent precipitation too.
And fix electrolytes. Treat pain.
Definitely fix electrolytes, especially potassium. Treat low calcium carefully due to rebound risk. For pain, avoid NSAIDs because they can hurt the kidneys.
Okay, clear. Now, toxicologia, M5T7.PDS, fundamentals of toxicological methemoglobinemia. Basic idea.
Methemoglobin is hemoglobin, where the iron is oxidized Fe+++ instead of Fe++. It can't carry oxygen, normally kept below 1% by enzymes in red blood cells.
Figure 1 shows those enzyme pathways.
Yes, the main one using NADH and the backup NADPH pathway that methylene blue treatment utilizes. Figure 2 shows the oxygen dissociation curve shift makes it harder for remaining good hemoglobin to release O2.
So, acquired methemoglobinemia is from toxins oxidizing the iron.
Exactly. Oxidizing substances overwhelm the body's ability to reduce the iron back to Fama++. Table 1 lists common culprits: certain meds like dapsone, local anesthetics like benzocaine, chemicals like nitrites, aniline dyes.
It mentions indirect versus direct agents.
Yeah, indirect ones need biotransformation, might cause more hemolysis, act slower. Direct ones act faster, less hemolysis usually. Nitrites are a classic direct example. Aniline dyes, indirect. Basic difference to know.
And specific situations. Infants in well water, toddlers eating stuff, adults with occupational exposure or using poppers.
Right, those are common scenarios. Infants are vulnerable due to immature enzymes and fetal hemoglobin. Nitrates in well water from fertilizer runoff is a known issue. Accidental ingestions in kids, occupational exposures. Nitrite inhalants, poppers.
Main clinical sign, cyanosis unresponsive to oxygen, chocolate brown blood.
Those are the fundamental clues. Cyanosis looks worse than the pulse ox reading might suggest. Standard pulse oximeters get fooled. Blood looks dark, doesn't brighten up when exposed to air. Figure 3 shows the color difference.
And symptoms depend on the level. Table 2 gives ranges.
Generally, yes. But factors like being an infant, alcohol use, G6-PDH deficiency, underlying lung or heart disease, they can worsen symptoms at lower methemoglobin levels.
Diagnosis needs suspicion plus confirmation.
Suspicion based on the clinical picture: cyanosis, poor O2 response, maybe exposure history. Confirmation requires co-oximetry, usually part of a blood gas analysis, to actually measure the methemoglobin percentage. Figure 4 shows portable co-oximeter.
Need to rule out other causes of cyanosis too.
Absolutely. Respiratory failure, shock, sulfohemoglobinemia, CO poisoning, cyanide. Have those basic differentials in mind.
Treatment basics.
Yeah.
Not always needed if mild.
Right. If under 20% and asymptomatic, often just remove the cause and observe. For levels over 30, 35% or significant symptoms, the antidote is methylene blue.
How's it given? Any warnings?
1% solution, 1 to 2 millidiaceolebs, IV slowly. Repeat once if needed. Crucially, avoid it in G6-PDH deficiency causes hemolysis. Also generally avoided in newborns and congenital types, can cause paradoxical methemoglobinemia if overdosed, interacts with SSRI's risk of serotonin syndrome.
What if methylene blue can't be used or doesn't work?
Exchange transfusion is the fallback for very severe cases, 60% coma, severe hemolysis, rare but effective. Ascorbic acid is mostly historical, slow, and less effective. Hyperbaric oxygen isn't proven useful here.
Okay. Moving to toxicologia M5T8.PDF, hypersensitivity and anaphylaxis from bite stings, mostly about insect stings.
Primarily Hymenoptera bees, wasps, ants as the main cause of severe allergic reactions, yes.
So need to distinguish toxic versus allergic reaction.
Fundamental distinction. Toxic is the direct venom effect, usually local, non-immune. Allergic involves the immune system, specifically IgE antibodies for type I hypersensitivity.
Toxic reactions are usually mild, local swelling, pain.
Mostly. But some spiders, snakes, or even multiple bee wasp stings, 50, can cause systemic toxic effects.
Allergic reactions can be local or systemic.
Right. Local allergic reactions are common, bigger swelling, 10 centimeters, lasts longer, 24 hertz. Systemic allergic reaction is anaphylaxis.
Anaphylaxis, the really bad one.
Yeah, potentially fatal. Usually starts fast, 15, 60 minutes. Ranges from skin symptoms, hives, itching, swelling, to breathing problems, GI issues, shock, coma. Table 1 gives the formal diagnostic criteria useful for exams.
Key animals, bees versus wasps.
Hymenoptera are the main allergy concern. Bees leave the barbed stinger, die. Wasps have smoother stingers, can sting multiple times, different key allergens in their venoms. Table 2 summarizes insect sting presentations.
Miters, snakes, jellyfish mostly cause toxic reactions.
Usually, yes. Anaphylaxis to them is rare, mostly seen in people with frequent exposure, like snake handlers. Viper snakebite severity is classified in Table 3 based on local systemic signs.
Risk factors for severe allergic reactions.
Prior severe reaction is a big one. High exposure beekeepers. Certain meds like beta blockers, underlying heart-lung disease, mastocytosis, high baseline tryptase.
Diagnosis involves history plus allergy testing.
Yeah, detailed history of the reaction, plus skin tests and specific IgE blood tests, done a few weeks after the sting. Tryptase level helps rule out mastocytosis.
Immediate treatment. Wash, cold, remove stinger.
Basic first aid, yes. Remove bee stinger quickly without squeezing the sac.
And for anaphylaxis, the absolute first-line treatment.
Adrenaline, epinephrine, intramuscular injection, mid-outer thigh, 0.01 mg/kg, max 0.5 milligrams per dose. Repeat in 5 minutes if needed. That's the lifesaver.
Benefits outweigh risks even in older patients.
Generally, yes. Don't delay giving adrenaline in suspected anaphylaxis.
Second-line treatments.
Oxygen, 4V fluids for low blood pressure, beta-2 agonists like albuterol for wheezing.
Third line. Antihistamines, steroids.
They help mainly with skin symptoms or preventing prolonged reactions, but they are not first line for life threats. Adrenaline is first. Glucagon might be needed for patients on beta blockers who don't respond well to adrenaline.
Long-term. Immunotherapy.
Venom immunotherapy, allergy shots, is effective for those with a history of anaphylaxis to stings, not usually for just local reactions.
Okay, last one. Toxicologia M5T9.pdf, emergencies with psychotropic drugs. Not overdoses, but other syndrome.
Exactly. Things like neuroleptic malignant syndrome, NMS, and serotonin syndrome, SS, which can happen with therapeutic use or interactions.
NMS, neuroleptic malignant syndrome, linked to dopamine blockers.
Primarily neuroleptics, typical and atypical, but also some antiemetics like metoclopramide, life-threatening. Key features: altered mental status, severe muscle rigidity, lead pipe rigidity, high fever, autonomic instability, tachycardia, unstable BP.
Risk factors.
Using multiple neuroleptics, rapid dose increases, dehydration, prior NMS, more common in young men, maybe due to higher doses used. Tables 1 and 2 give diagnostic criteria, know the basics for your exam.
Differential diagnosis is important. Table 3.
Crucial. Need to distinguish NMS from malignant hyperthermia, anesthesia link, lethal catatonia, heat stroke, severe Parkinsonism, CNS infections, serotonin syndrome. Key differences are often the type of muscle tone change, rigidity versus hyperreflexia clonus in SS, and lab findings, high CK, leukocytosis, and NMS.
Treatment for NMS.
ICU admission. Stop the offending drug immediately. Supportive care is vital cooling, hydration, maybe ventilation, specific drugs sometimes used, dopamine agonists like bromocriptine, or the muscle relaxant dantrolene, especially if very high fever or rigidity.
Okay. Then serotonin syndrome, SS. Too much serotonin activity.
Yes, usually from combining drugs that boost serotonin, SSRIs, SNRIs, MAOIs, tramadol, triptans, St. John's wort, even methylene blue. Table 4 lists many. Cocaine, amphetamines too.
Clinical picture. Triad.
Autonomic changes, tachycardia, hypertension, sweating, diarrhea, neuromuscular excitation, hyperreflexia, clonus especially inducible or ocular, tremor, rigidity sometimes but less than NMS, and altered mental status, agitation, confusion, coma. Usually rapid onset within 24 hours. Table 5 details symptoms by severity.
Diagnosis is clinical. Hunter criteria useful.
Diagnosis is clinical based on history of serotonergic agent use plus characteristic signs. The Hunter criteria, Table 6, are highly sensitive and specific, very very useful, though those criteria. Differential diagnosis, again important, Table 7, NMS, anticholinergic toxicity, etc.
Treatment for SS.
Stop the serotonergic agents. Supportive care fluids, oxygen, monitoring. Benzodiazepines for agitation. Cooling for hyperthermia, antipyretics don't work well. The antidote cyperheptadine, serotonin antagonist, can be used in moderate to severe cases.
Briefly, acute dystonias, sudden muscle spasms.
Yeah, involuntary sustained contractions, often twisting movements, frequently caused by neuroleptics, Table 8, especially in younger people, can affect neck, jaw, tongue, eyes. Oculogeric crisis. Very distressing, but usually benign.
Treatment for dystonia.
Anticholinergics like piperidine IV or IM usually work very quickly. Benzodiazepines can help too. Reassurance is key.
And drug-induced Parkinsonism. Looks like Parkinson's disease.
Exactly. Caused by dopamine blockers, especially typical neuroleptics, but also some other drugs. More common in the elderly. Onset is gradual, weeks to months. Tremor, rigidity, slow movement.
Treatment.
Stop the offending drug if possible. If not, switch to a lower-risk neuroleptic, clozapine, quetiapine, or use anticholinergics or amantadone. Levodopa doesn't usually help drug-induced Parkinsonism.
Wow, okay. That's a lot of fundamental ground covered for the exam. From the initial approach, legal stuff, safety, right through to specific syndromes like rhabdo, methemoglobinemia, anaphylaxis, NMS, SS.
It really lays the foundation. You see how it all connects: assessment, legal duties, complications, safety. Yeah. It's all part of managing the intoxicated patient effectively. Definitely review your notes on these core areas.
So thinking about everything we've just discussed, all these fundamental pieces, considering this foundational knowledge across these essential areas of toxicology management, what do you think is the single most fundamental element for a healthcare professional to master in the very initial management of a poisoned patient, keeping in mind the need for a broad and basic understanding? Something for you, the listener, to ponder.
Good question to reflect on.
Thank you for joining us for this fundamental deep dive.